Thank you, everybody, and good morning. Thank you for those present and those virtual. And I want you to join me, and I invite you to give me a few seconds. I know we have limited time, but really your relaxation, serenity, and peace, and honor the senseless injustice and losses of life in our country and in the world in the last few weeks. Yet, despite all of this, I have the privilege to be with you all today with a group of very caring people trying to make a positive difference for those who we serve and our community all. And for that, I'll thank you all. Today, I hope to organize my talk in 3 different sections. The first one is trying to provide a glimpse of the important key issues that we need to understand for making sense of the anchor results, but also to understand what the important anchor study was tasked to do. Of course, the second section will dive into describing the granular details of the anchor study, the methodology, and its results. And I want a few minutes to share with you some thoughts about how we constructively, with the still many unknowns, use these results in a positive ways and move forward for the benefit of our patients. So you see on this graphic, there are the following concepts to be highlighted. 50 years ago, anal cancer was a neglected disease that occurred in less than 0.3 per 100,000 patients years of follow-up. The second point to make is that in the last 50 years, without a doubt, the absolute number of invasive anal cancers occurring in women in the United States. But the proportion of increase of cancer has been 3.5-fold in the last 50 years, whereas in men, it's been 8-fold, and there is an increasing continuous sustaining rise. I want you to bring to the attention that these sort of 2 per 100,000 years of follow-up are general rates, all comers in our general population. This audience know quite well, and this is perhaps the most elegant study with multiple compilations of thousands of patients, show that unequivocally patients with HIV, regardless of the preference, yes, with some ladder based on age, have an increased and disputable risk relative to the general population or those without HIV. Relative to the anchor study, I want you to focus your attention in the left upper part on the red dots of the slide. It shows that even if you are in the highest of the highest risk category of patients with HIV, having a rate of 100 per 100,000 follow-up, that means that you are in the highest of the highest risk. Again, 100 per 100,000 years of follow-up. And I want you to remember this number because it's important for what we are going to discuss later. Why this is happening? Many things were learned from cervical dysplasia. In the anal field, like in the cervical dysplasia, there is one key word: persistent HPV infection trigger a sequential, longitudinal, nonlinear histological changes that go from low grade, intermediate, and very high grade. And when those lesions start to invade the laminal propria, we call it invasive cancer. And we learn from cervical cancer that treatment of those lesions at the personal and public health level is proving to reduce the incidence of cervical cancer. So it will make perfect sense to do the same with anal lesions. Yet there are important caveats for which we need to prove this for relevance and what anchor was tasked to do, because there are considerations. On the left-hand side, you see a bidimensional plane of a cervical colposcopy. So you see the entire cervix exposed, And in bidimensional planes, you can even implement a therapeutic treatment such as sleep and remove the entire anatomical area of risk. On the right-hand side, you see one of our pictures of one of the levels of the anal canal that shows that even with the best exposure, it's a collapsing space, and you need to work carefully to expose every single area. Again, you are not entirely seeing all the area at risk, because some patients could have disease all the way to the perianal canal. In other words, we are now working with a collapsing virtual cylindric-like space. And here's where some of the important challenges and unknowns came. Number one, the obvious, that you have the difference in topography, where you really need experience and skills in order we can make sure that we are doing a complete staging procedure and you don't miss any lesions. But at the same time, you could have lesions at different levels of the anal canal, and that has two practical connotations. Number one, it requires multiple treatments. And number two, unlike the cervical canal, when you can remove it all, it's not very clear how we choose the microscopic margins to treat and destroy the lesion. We try to do it in the best possible way with the current available methods. But I want to highlight another important consideration that hasn't been addressed well, but it's very well documented in the evidence. Some think that there is also difference in the way how the cervical and the anal compartment behave immunologically. And they try to speculate that they are sort of different compartments. And the evidence is pieced from two concepts. Number one, if you compare multiple studies with women with HIV without any history of anal receptive intercourse, and you do concurrently evaluations of cervical and anal canal, you find that the proportion of histological HSIL and persistent high-risk HPV is much higher in the anal canal than in the cervical. And then the other important concept that all of you know, the one virus, one lesion that we know in the cervical canal doesn't apply to the anal canal. And what I mean by that is in the standard of care in our assessments for cervix, we do a swab, we often find an HPV, and in 99% of the cases, that is what you will find on the histological lesion driving the risk of cancer. In the anal canal, you do a swab, and you find multiple HPV viruses, and not every identified virus it's associated with the disease, and sometimes none of those identified correlates what is driving histologically the risk. And that's where people are thinking, we need to understand this in a better way. And that also explains why, when you think about this, as an example, in San Diego, there are 359 professionals that can do everyday cervical colposcopies for anal cancer screening. In the state of California, we have less than 40 medical providers doing high-resolution anoscopies, and sort of illustrates the challenges and the work in progress on the field, and for which we needed the anchor study to really provide important guidance and information. And now that we are going to talk about the anchor study, I think it's important to remember three therapeutic concepts that we knew before the start based on prior randomized clinical trials. That the treatments that we have, the ablations, are very effective, particularly to treat lesions inside the anal canal. The topical treatments are poorly tolerated. They are really something that patients don't like, require multiple months of therapy, and ineffective inside, and usually reserved for some treatment of perianal lesions. And the other concept that using any HPV vaccination as a coadjuvant therapy when someone has HSIL is not really useful. And our antiviral research center participated a decade ago in doing this study, the A5298. And that is being confirmed by several studies later. Prospectively, we know that there is no utility when someone has already the HSIL as a secondary prevention. And with this, AMCOR came with this background to answer two main questions. So if we start treating high-grade lesions in the anal canal, are we going to really decrease the incidence or, pardon me, or the prevalence of HSIL, like in the cervical canal? And more importantly, can we do it safely? Yes, there were other study aims that we don't know still the results, and it's not really relevant for this presentation. So for this, what the study was conceptualized is exactly to power in a way that addresses this question, trying to get a difference of meaningful 50 between 150, between 50 and 150 per 100,000 patients year of follow-up between observation and treatment arm. And it was powered in such a way that is a event-driven analysis with the primary outcome counting from the time when you randomize somebody to when the event of developing anal cancer occurred. And approximately more than 2,500 patients in each arm needs to be enrolled with an estimated 31 event cases to try to provide a meaningful answer to this question. And the study was supposed to be set up and start in 2014. And the slide that I'm showing you represents, on my mind, two important concepts. Yes, 17 participating sites across, 13 states were part of the study. And the major kudos, of course, goes to a group of cadre of colleagues led by Dr. Yuval Paleski and my colleagues from UCSF, who really accomplished unsurmountable obstacles and efforts to really conduct a study that will be hard to replicate. And it's really couldn't be understated how complex the protocol is and how they deliver. But the real major bravissimo go to our study participants and patients, because they trust, they commit, they support the science to try to make a difference, and then subject themselves to very complex and exigent study protocol. And my thank you to them, and we couldn't be really more grateful for their support. And in short, and basically, what the Anchor study is as a major screening criteria, they performed a high-resolution anoscopy on anybody. Initially, they didn't need to have HSIL or high-grade lesions as a criteria. And if they do a high-resolution anoscopy, if there's a lesion, they biopsy. And if HSIL is found, the patient then gets into the study and gets randomized. And there were two potential arms. Either you get treated or you get monitored periodically. Of course, if at the baseline you have cancer or something different than HSIL, you don't get in the study. Are we clear so far? Do we have any questions here? Okay, so let's keep moving. So when you look with more granularity about what it was done, at every visit, particularly in the screening, two things were done: anal swab and high-resolution anoscopy, with or without biopsies, depending on the clinical criteria. And the anal swabs were for cytology, for HPV and other markers that they are trying to investigate. But here's the important component that I want to highlight. The randomization after someone was found to be HSIL positive followed three criteria. Number one, the most important clinical surrogate marker of persistent HPV, which is the nadir CD4 cell count based whether patients have a CD4 cell count nadir of less or more than 200. Number two, the burden and how complex it is to treat the disease, given by the extension, whether the amount of disease extended more than 50% or less than 50% of the anatomical area. I show you that this is a cylinder. I suspect that this is based on 50% of any given level, not the entire anal canal, because it will be not possible to treat it. But I think more details need to come on this. And of course, we discussed experience matters, and there were specific sites that they were trained relatively soon to enroll patients, and they have to stratify based on a cortis site because different outcomes could happen based on the experience of the operator. We have a question.
There was a question. There was a comment from Jeff Taylor saying, as a member of the Anchor protocol from the beginning, we can't overemphasize Joel's Herculean work in getting this through the NCI NIH bureaucracy. And then credit to Bob Yerchoen. That's just a comment. And then Darcy asked, and I think this is an important question. How is it determined who would get anal paps?
Now, so there was no anal pap as a criteria for the study enrollment, right? The study enrollment immediately recruit everybody for a high resolution anoscopy. And on the results sections, Darcy, I will show you that was a trouble because there was a very slow enrollment between 2014 and 2016, approximately. And the study then, to try to boost enrollment, need to include patients with a priori known history of HSIL, that they know that they have disease already, to be screened and randomized. Okay. So
I guess the follow-up to that is that how did they decide who got high resolution anoscopy? Was it just anybody who, you know, met criteria and was interested in being in the study?
thank you, Darcy. Anybody who consider themselves to be at risk, they will be screened for the study, and the screen from the get-go require a high resolution anoscopy. Okay. Any other questions? I think very important point. Thank you, Dr. Wutem. So the interventions, not secrets, ablations of the most common kinds, whether really recoagulation, electrocautery, hybridification, and there are not really major difference between those techniques. Is providers and operators' preference, and topicals were used, mainly imiquimod, and oral data, and topical 5-fluorouracil. That was the interventions that they were provided for treatment. And I will expand this on the results section. So when you look with more granularity, this is how the study protocol flow. So from the left-hand side, you see, if you find someone on a screening high resolution anoscopy, and is found to have an HSIL biopsy, the patient gets randomized based on the criteria that I present to you, and immediately within 2 months, maximum 2 months, they get for visit 1, where they get treated. If they get treated, then they are followed every 6 months for visit 2, where they get reassessed and they get another biopsy on the similar or other areas. If the lesion is present, again, within 2 months, they get retreated, and they keep the follow-on every 6 months. If the lesion is present, a third visit, approximately 18 months into the monitoring, immediately get treated again. But here's the caveat. After you fail 2 consecutive treatments with the same ablation procedure or whatever you start at the beginning, you switch to a different strategy within the scope of the treatment protocol. And this could be going on every 6 months. At every time point, high resolution anoscopy, cytology, as well as HPV testing with biomarkers were done as part of the research study. If you are in the monotherapy arm, you also get to be monitored every 6 months, but you don't get a biopsy every 6 months. You only get a biopsy annually for 2 reasons. Number 1, to make sure that the lesion hasn't progressed to invasive cancer, or as many of you know, that the lesion hasn't spontaneously regressed, because this could happen. Unless there is a strong clinical suspicion that the operator feel compelled, oh, I have to biopsy this early because this could be cancer. Okay? Any questions? Yes, Steve. It's part of the study protocol. There is no really well-defined interval follow-up. When you have an HSIL lesion, not every HSIL lesion is the same. It could be AN2, it could be AN3, it could be 1 or multiple. I think the shortest interval that you will recommend probably a follow-up is between 4 to 6 months. So we will consider sort of within the acceptable standard criteria or those who practice on the field. But nothing on this field is really a standard of care. Okay, there is a follow-up question from Steve.
So the 2-month reevaluation, that is like standard, or is that kind of like a pattern?
Okay, so what the serious question is, when someone gets a positive HSIL and you treat him within 2 months, is that really a tight interval? Yes, the recommendation is between 3 to 6 months, and based on the access, availability, and local resources, there are places where when you find HSIL and you bring the patient back for an IRC, it doesn't happen so quickly. Well, everybody needs to remember that this is a very slow progressive disease. And after 5 years of having HSIL, the chances of developing invasive cancer is only 2%. Okay, so let's keep moving so we can have some time to more conversation. Thank you very much for the questions and for the clarifications. And really, what you see is that you have more than 10,000 patients, close to 11,000 screened. I already explained you the natural challenge that the dedicated study team found, because at the beginning, they were doing a lot of high-resolution anoscopies, but really not presence of HSIL. So the criteria was open up a little bit more, and ultimately they were able to enroll or identify close to 6,000 patients with HSIL, of which ultimately 4,446 were randomized and included on the study. We would like to know why a non-insignificant 26% of patients with HSIL did not enroll or agree to participate in the study. So I'm sure we will find out more details, but I think that's a very important number to pay attention to. Challenges of the enrollment are really real, despite the best effort of investigators, and they have to really open up the criteria in order they can really accomplish a meaningful study accrual. So the following slide shows the following concepts. Number one, between the monotreated arm and the study arms, there were really no demographics, age, or difference. But the study population, it was really composed, number one, by people with a long time of HIV infection in median of 17 years. They were having a median of early 50 years old, primarily composed of people who were male, particularly men who had sex with men, close to 78 to 80%. Almost 2/3 of the study participants were non-white. When you look at the more detailed characteristics from other risk factors between both arms, there were no difference. But the study population, in general, have a very low percentage of patients with history of smoking. The great majority, close to 80% or above, I believe, have very well controlled and detectable HIV viral load. At the time of study enrollment, they have very good CD4 cell count, but this is the most important. I think that 1 in 2 of those patients, at some point, they have a very low nadir CD4 cell count, less than 200. For the consideration, the technical considerations of the management, a little bit more than 1 in 10 patients ultimately enrolled, they have hardcore multifocal disease with more than 50% of anal dysplasia involvement. And I think this is a very important point, and I want to give you a picture so you understand the issue of the 50%. This is an example on the left-hand side of a patient with 25% of disease in the squamo-columnar junction. And this is after successful treatment, and you see you really need to expand the limit area of the treatment to make sure that you cauterize everything all. And we really try to do treatments when they are no more or less than 50% at every single area, because the rate of complications and patient tolerance are quite high. So we'd like to see, I'm sure, the treating providers, the details, how they manage patients with more than 50% of disease. It's really challenging. So the treatments that were provided show that everybody got an ablation of any kind. And if you look at the table, in addition, 8% of people also got topical therapies. I don't know if this table represents the cumulative treatment after multiple failures, because I don't foresee that when you're doing ablation therapy, you can also do concurrent topical therapy. That would be absolutely very difficult to implement. So I suspect that's the case. And I think the meat of how complex was the treatment protocol is as follows. As I present you in the prior table, the median time follow-up, it was 24 months. That means that really many the average patient have at least 4 consecutive high-resolution anoscopies in addition to the one that they require for randomization and study eligibility, and minimum in average. And among them, 10% of them require at least 2 different types of treatment modalities, which means that they fail at least 2 prior therapies. And within that, a non-insignificant 2% of patients fail at least 6 therapies because they really have 3 modalities. And even 1 patient has recurrent persistent lesions. Whether the lesions were in the same anatomical area or in a different anatomical area, I think we will find out. But it's clear on the preliminary analysis that they show and discuss, like we know, practicing on the field, the burden of disease, the multifocality of the lesion was an independent criteria for developing invasive cancer. And this is really part of the study, and I want you to remember my second slide. So on the treatment arm, the rate of invasive cancer was 173 per 100,000 patients of follow-up, and in the monitored arm, it was 402. But regardless, from every angle that you look at, this reflects the highly selected of the highest risk population because of the numbers that I already presented you on the second slide. But of course, the difference between the treatment and the monitored arm provides you a valid and undisputable 57% decrease in the risk when you treat a lesion, that lesion becomes anal cancer. And this is the Kaplan-Meier that I'm going to provide you in more detail in a few seconds that shows something. There was, as I like to see after the curves start to really opening up after the first year, but I want you to pay attention around this area. There was a lot of action and noise during the first 6 months, and I think this is important. How safe were the procedures? As you will expect, the higher rate of adverse events happen in those patients in the treatment arm, and non-insignificant 6% of patients have important side effects, mainly related to pain or topical complications, even with ulcerations due to topical treatments. Very rarely happens abscesses when you do a biopsy or when you treat, and they have few cases. They didn't have really major bleeding episodes, which is one of the other complications that happen with treatment of these potential lesions. So with this, the study concluded that really, as the data shows and the evidence favors, that really treatment of anal HSIL is effective in reducing anal cancer. The call for this to be officially included as a standard of care, they acknowledge that what I'm going to address in our last part, the importance of optimizing how and who to screen with the algorithms that we currently have existent. Of course, I have shown to you the importance, if you're going to implement this, to scale up trainings for having medical providers to provide the services. And I think it's a very humble and accurate acknowledgement that we currently need better treatments because the current strategies focus on the lesion and not in the virus. It's not available so far. So I'm going to stop here. Yes.
Just very quickly, because there's the same few questions in the chat over and over again. And I just wanted to clarify. So from the screening, in order to be considered to actually enter the study or be randomized in the study, could it have been just the anal pap that showed HSIL?
No, the histological proving.
Had to be that.
There
Okay, everyone
was,
got it?
there was no anal pap prior to any high resolution anoscopy. If I were interested to participate on the study, I will sign up for having a screening high resolution anoscopy and wait for the procedure to identify an histological HSIL in order I can be considered for enrollment and randomization.
But there was an anal pap done at the same time.
Concurrently.
And then I think a lot of people, and I don't know if you'll present it, people want to know about the correlation between the two. I don't know if you get to that later.
There is no data on that. It's one of the elements, and I think that's part of my conversation at the last of the talk. But one of the key questions that many of you have in their mind is, how does it correlate to how many number of patients we need to treat? And I think there are 2 ways how we can do this. Number one is, and I chose the first one, which is following how the study was designed based on the power difference in rates. It's very easy to calculate the rate on the treated and the control arm and calculate the difference. The formula is on the slide. and you actually have you need to treat 438 individuals in order you can prevent one of those patients to develop with one of those progressive lesions invasive cancer. There is another way how you can do this, which is if you try to compare the rate between the absolute number of patients that they were detected, 21, and 9 in the monitoring and treatment arm accordingly. It's not how the study was powered, but if you want to do the math according to that criteria, the number of patients needed to be treated is 184. Why? I argue that could be a little bit tricky. I want you to look at what happened in the first 6 months, and I actually amplify this for you. You see, I'm not going to count the first dot at time 0 in the treatment arm. It's there, I don't know. I think they didn't count it. So I'm going to count only that happened 2 events within the first 6 months. And in the monitoring arm, there were 4 events within the first 6 months. And as I mentioned in my response to Steve, this is a very slow progressive disease. So it's very unlikely that someone will really develop cancer within the first 6 months. And in fact, most of the studies about the natural history of the disease chooses as a criteria to exclude patients diagnosed within the first 6 months because most likely they represent cases that the lesions were missed due to complex technical criteria and eventually self-declare. I think that is important if you just want to compare the absolute numbers because I think I rather stay with the comparison of the epidemiological rates, how the study was powered. And I'm going to give you a practical example why this is important. This is a real patient who came and was referred to us approximately a month ago. This patient has HSIL, and when you do an anoscopy towards the distal part of the anal canal, you see like a wart-like area. Also, you see some concerning this plastic tissue. But what makes a difference when you're examining this patient is you're doing a digital rectal exam and you feel some funny indurations. So I could have taken, like I discussed with the patient, immediately biopsies, but the biopsies in the high-resolution anoscopy are not excisional biopsies, and when you have such a high-risk circumstance, it's preferable an excisional biopsy. We coordinated with the surgeon. He was seen within 5 days. Within 10 days, had an excisional biopsy, and the patient had invasive cancer. Have I not chosen a different approach, I will probably choose like the formal anatomical pathological response set, a lot of HSIL with AN3, and miss a probably deeper lesion that could have self-declared like a mass in the next 6 months. This is the reason why I'm very careful to consider and analyze what happened with the first 6 months when someone gets diagnosed with cancer. And the other important question and point and consideration for our patients is that once we treat these lesions, unlike the cervical canal where you do a lip and destroy, remove the entire area at risk, here, any potential treatment and the study design of the anchor trial prove it, requires ongoing monitoring, and the patients need to understand that we successfully could treat lesions, the fight and risk is not over. Okay? So, and there is another important key factor that we are going to learn more details, which is, do we know, in addition to the correlation, the cytology and histology, etc., that those in the study with a very high risk population, because those studies are largely known and published, were there any patients in addition to those who progress, who regress? Because we know from 100 patients with HSIL, approximately 50 will stay within HSIL in 5 years. 2% will progress to basic cancer, and close to 45% will spontaneously regress. Unfortunately, when you diagnose someone today with HSIL, based on the ERT, whether they are suppressed or the C1 account, we cannot tell who will spontaneously regress or who will progress. Hence, the paramount importance of anchor study to show that it's extremely valuable to identify patients with HSIL. Some of them are truly at very high imminent risk of progression to cancer. And that is a very important point. And the anchor study shows that treatment of many of those patients decrease the risk of anal cancer. So to address the last part, I will stop here and take any questions that you may have. Okay.
Nettie, do you want to share anything right now?
No, I just am so impatient. Thank you, Lalo. This has been really helpful. And I think for many of us who are on the outpatient side, trying to decide how to do the screening side of things, we're all anxiously awaiting some more information on that correlation between the anal pap screening and the HRA results, so that we can know that our anal pap screening is effective, and sort of have better sense of what we need to do on the front end. Because I think we've seen, with other screening tests, that even if identifying and treating the cancer is extremely important, how good is the screening test? So I'm really anxious to see that part of the data, and I was wondering if they had given any sense of when they're going to present the correlation.
Well, we know the diagnostic operating characteristics and the correlations, and I'm sure we will find out more details. There are multiple studies that show, but you're right, Nettie. This is one of the most important conundrum in our clinic. And unfortunately, as most of you who work in the field know, any of the available swab-related immunomarkers such as HPV, microRNA, specifically microRNAs 47E7, increases sensitivity but decreases specificity when you combine with anal cytology, and alone are useless. And when you do immunostains, they increase the specificity, but again, are immunostains and require of the biopsy. So we know currently that the most reliable, with all the caveats, diagnostic screening is cytology. And to your question, Nettie, let me share with you the far part of my slide. So we can focus right now in a deficit mindset, focusing on the granular details that we still need to learn from the anchor study, the lack of consensus in certain key populations about how to screen based on the IDSA, HIVMA, or DHS guidelines. We can also highlight that it's controversial that they ask us to start getting into the risk behaviors of our patients that for many proven to be uncomfortable and associated with the stigma, and I will argue with post-traumatic stress disorder, and could inappropriately mislead our risk criteria and so forth. So what I propose is, this is a valuable field-changing study, and I propose an equity mindset, which is, what can we do with that? And with all the knowledge that we have. And this is exactly what I'm trying to present in the last few minutes.
8:40, you're good though.
Thank
Take your
you.
time.
So there are two questions, Nettie, and everybody. So give me the microphone. So you are, you are on your clinic and you are telling your patient, I think we need to do an anal cancer screening. And your patient consider herself or himself not at risk despite having HIV. So my anal pap, do I need to do this? Plus some comfort of, undressing the patient. What are the risks if I don't do this? So one question is, what is the probability based on the anchor study of having an HSIL on anal cytology? That's one question. And the other one, if you have an anal cytology with HSIL, what is the probability and how it translates to a histological HSIL? So I think for that, we have some contributions. The OWEN team try to look at this with a lot of carefulness, knowing the importance of the findings. There is a rich experience for more than 20 years. Everybody knows that since 2001, we have a policy that recommends universal screening just for being HIV, not for any other risk factors. But diversity is good, and everybody knows in the evolving field of heterogeneous perceptions and also guidelines, not everybody has done screening in the same sense. We set up to understand what is my true probability on a first time anal cytology in whom I've never had really any anal cancer screening with clinically available criteria to have HSIL. Because I just said that not everybody is being screened, and please, I'm not going to make this conversation about statistics, but we need to know that we need to adjust using special methods such as inverse probability weight analysis to adjust for who is being screened relative to the population at risk that require to be screened. So very briefly, I can show you that in all of these years, in more than 8,000 individual patients, 1 in 2 of our patients have actually received anal cytology screening. And the data shows that those who were less frequently screened were female, African Americans, non-Hispanics, and males who did not have any history of having sex with male. There were no difference based on the number of clinics, the type of follow-up, the gender identity, the CD4 cell count, etc. And this is just the factual reference despite having a universal screening criteria. And then when you look at the distribution, there are two important points to highlight. Number one, that when you do an anal pap, you will have any abnormality in 65% of your patients, like we did, and 12% of them have HSIL. Yet, when you look at the specific characteristics, you see patients who were MSMM, particularly with a prior history of intravenous drug use at some point, they have a risk of 16%. The risk, actually, it was 17% if they have a CD4 cell count nadir of less than 200, and so forth. But from your standpoint of view, when you're in clinic, patients are not just risk factors. They are really it's accumulation of different clinical combinations. And for that, we need to use different, I'm going to skip some statistics, but you need to create some models that try to combine and validate the combination of all of these factors. And we ran several models, and we come up with this probabilistic table that I'm not going to describe in detail that basically identifies important criteria. We know the sex, the identity, the HIV risk factors when someone is discussing with us in our clinic. We know their age, the ethnicity and race, whether they have ideally a nadir CD4 cell count. And more importantly, the table is showing you who is at risk or not. For example, if your patient has a nadir CD4 cell count above 200, the chances of having an HSIL are really decreasing by 50%. But having a table with dots you can read on your spare time is not useful to your patient, it's not useful to you, perhaps when you're in busy clinic, and it's nice for a paper, but it's not practical, right? But you can translate and apply this knowledge after you validate it, calibrate it, and proven to be useful in something which is the most important, which I think is useful for the clinical practice. And I'm trying to share the concept, which is a practical nomogram. All of these factors can be applied in a practical nomogram when you have a card on your clinic. And even if your patient is not sure or you have some shortcomings about the indication, you can engage in a shared decision conversation with your patient. So I'm going to show you an example how this works. And I am with a patient who is 55 years old, non-Hispanic white, heterosexual male, with an history of a CD4 cell count nadir of 375. The patient rightfully say, I don't know if I really need this. I've never had anal sex in my life, and I'm not at risk. My current CD4 cell count is 1,000, and I'm very healthy. So if you plot these numbers, first of all, he's 55. So you trace a perpendicular line more than 50 from the score, his score for H0. You do the same for being non-Hispanic and white, and it corresponds and matches with 7. You do the same for his other risk factors based on being heterosexual and never have sex with male, and matches perpendicularly with his score with 7. And you do the same for his nadir CD4 cell count. And what you do next, once you calculate based on the individual risk factors, and this is a card that you have with you in your clinic, then you immediately, in the step 2, add all of these subscores, which equivalent to 7. Okay, what do I do with this? Basically, you match the total score that you just found with the probability table here at the bottom of the nomogram, and it tells you a risk of approximately 6.7%. So with this patient, with these characteristics, you have approximately 7% risk of having an anal HSIL. So you could argue, say, well, is that good enough? If I have a 6 risk percent, it's not 0, 6% risk of having an HSIL, is that enough to consider a screening? Well, I think I can disclose in fully how this works. Don't look at the entire table, but basically, I could argue that when you enroll in a screening, if you are not screening everybody based on HIV status, we need to choose, particularly when there is a low risk minimum invasive test, that we fail to recommend a screening test in someone who otherwise could have the condition. And for that, we really need to look at very high sensitivity. And in the table clearly shows, based on the validation of this nomogram, that 6% is associated with close to 90% sensitivity. You rightfully could say, well, the specificity may vary. So look at the number of patients who are properly classified, 17%. So practically what it means is If we decided not to screen patients with 6% of risk of having HSIL, it means that every 25 patients that we decided not to screen, we are going to miss 4 patients who could have HSIL. So I think this practical nomogram tells you that allows you to engage in a shared decision conversation with your patient and use other clinical relevant factors that may surface during the conversation and engage. This is not to convince you that you need to really do a screening, which I will favor in every patient with HIV, but really the patients must be engaged and participate and understand the meaning of the decisions. And to the last point, part of the controversy, Darcy, Nettie, and everybody for when you look at anal cytology is because all of the operational diagnostic characteristics are based on the gold standard, meaning I do my anal pap, it's HSIL, and then I send the patient to Daniel Lee, who does a biopsy, and he found that it's low grade. Oh, so the problem with every single analysis is that it assumes that this is a gold standard, but this is a fallible gold standard that requires a lot of experience. And therefore, you have a patient with an anal cytology results that you think that is a false positive when it actually could have been a mislesion. So in order we can answer the second question, and I finish here, you need to calibrate, again, I told you no statistics, but when you calibrate all the potential scenarios based on cytology performs, you will see that that 12% of population level that we have in our clinic could translate into an histological as low as 9%, all the way to 26%, a non-insignificant number for patients with HSIL. So I think I'm going to stop here and say that unequivocally, the Anchor study demonstrates that treatment of patients with certain anal HSIL reduce the risk of anal cancer in 50%. But we need to understand that the successful treatment of one lesion doesn't eliminate the risk, and patients need to be consoled appropriately. In the absence of any existing biomarker, not even in the foreseeable horizon, what we have in cytology, it's a very useful basis to really discuss the considerations for when and how to do a screen. And that thing from the OWEN clinic is providing you now a new nomogram that can practically be used to try to engage in a shared decision-making, particularly when there are stigma, misconceptions, or considerations on how to do the screening, because what Anchor show is that identify patients with potential anal HSIL is very important for clinical management. I want to thank everybody of each of my colleagues at the OWEN clinic who tirelessly and inspiringly care for our patients every day and contribute to every effort to improve their quality of life. Foremost, the resilience of our patients. Of course, the always scholar support of our ABRC, CIFAR, the Pacific Age Training. A personal note to Dr. Matthews, who have the vision to found the program, probably have saved many lives by doing so, and who trained me, taught me everything that I know in this field. And my daily inspiration, my colleagues and group of team, Tari, Patrick, Robert, Bar, who work every day in the anal dysplasia program. I'm happy to take any questions here.
Thank you, Lalo, for that excellent presentation. I noticed on the anchor slide in terms of the, I guess, the places where it was done, I did not see that UCSD was a site. And so that was kind of curious to me as to why that was the case.
The study enrollment started in 2014, and not a secret to everybody. The study required to have at least 2 operators to be able to provide the study screening criteria. At some point in our clinic, we have 6 HRA providers at any given time point due to different challenges, patient chain practices. By the end of 2013, between 2013 and 2016, and we have only 1 provider who tried to support more than 3,500 patients in the screening program with all the caveats that came and et cetera, et cetera. There are a lot of granular issues with the level of support from the UCSD health as a whole. But we kept the mission. And that's one of the main reasons we didn't have the human capacity to qualify for enrollment, only one provider. Yet, we were able to train Tari Gilbert, amazing provider, amazing colleague. Now, Dr. Dice is also undergoing training, and the mission continues. We are here to serve.
Would anyone else like to unmute? There were a couple of questions. Here, wait. Oh, Nettie, do you want to unmute?
I'm still trying to, apply things immediately. I agree with Darcy. This is super helpful and very applicable to patient care. So thank you, Lalo. And I was wondering what folks were doing for age at initiation of routine anal pap screening. Thanks.
Nettie, you are hitting the nail in the head. A very astute and smart question as always, because I can tell you we get the same comment from the reviewers. And I can share you, as you see in our model, age by 50, we have a little bit lower prevalence of HSIL compared with young. There is something undisputable that I want to say about this field. Number one, prevalence of anal HSIL in young people is high, 34%. National study that we have conducted and published recently with Joel Paleski. The data is there. The caveat in patients who are 18 to 26 with HIV, more than 1 in 3 have already anal histological HSIL. The caveat is that we don't know the significance of it because there are rare episodes of cancer in young people, and no one really has studied really the issue. What is undisputable, Neri, is that HPV clearance and reinfection also occurs frequently at a young age, particularly when they are not vaccinated, for which I couldn't emphasize the importance of trying to do preventive vaccination in young people. And I think what we are seeing is that although there are fewer cases of HSIL at an older age, they are probably the ones with persistent HSIL that really are at the highest risk of progressive to basic anal cancer. And the reason why probably the most two important studies for screening of cancer, such as SPANC from Australia and the one anchor, start the screening at age 35. Now, from the prevention standpoint of view, what is the youngest patients that I've seen on my clinical practice with anal cancer? 37. So that means that this patient probably have anal HSIL since he at least was probably 25 easily. So do we have a consensus? No, but I think future studies requires a longitudinal assessment, plan analysis, also in our team, to understand those longitudinal covariates in the risk of progressions to invasive cancer among those age.
There was a question about vaccines, and Jeff Taylor is going to ask it, and Aaron had a question also. So hopefully it'll all come together. Yeah. Last question also, everyone.
Yeah, thanks, Jill, and thank you, Lala, for all this. It's been an amazing study, having been on the protocol team since its inception.
Thank you for your service.
Absolutely. So just curious to know what the uptake is of vaccination in both your clinic and maybe the other providers. And also if you ever consider vaccinating people who are above the recommended age. I think it's currently 26.
Yeah, there are two elements. I will start with the last question. I think we are very proactive, I don't have the exact number, to try to vaccinate everybody which is age appropriate. I actually feel that the last part of the question is very straightforward. We have two elements. So I want to remind everybody that the reason why the ACIP expand the age appropriate limit is because when they did cervical studies in particularly larger Central American women, they have fewer levels of HPV exposure and they benefit from additional prevention and extension because they did not have HSIL already. And that was a rationale for which very proactively we in clinic not only offer to whoever is age appropriate, but really to whoever could do the catch-up area. Now, if you ask me above the limit, it's tricky because number one, it will have to be out of pocket. And number two, we don't have any good guidance of evidence. Something that I can say is, Tyler, that when someone has already HSIL, unequivocally for secondary prevention, at least to the already identified phenotypes that are in the nanovalent vaccine, there is no additional benefit. And I have already shown you, even young individuals really have a very prevalent of HCL. So what is my practical thought on this? We've been working tirelessly for the last 2 years with our microbiology lab to implement HPV swabs. And we are now in the validation process. To all my colleagues, OWEN Clinic, please wait for an email follow-up on this. We're hoping to evaluate what is the practical utility. Your patient may have HCL, but he could have clear lesion. But I think you can do an anal swab. If he doesn't have anal cytology or HPV, even if it's 43, the patient will benefit from Cachay vaccination. And I think that's the most accurate way. But if someone is 43, already have HCL, and it has already exposure, the chances of benefit are much less, no evidence.
Thank you.
You're welcome.
And Erin had asked about Gardasil or HPV vaccines, and it was an exclusion for the study. Is that correct? They could not have had,
I believe
And-
so.
could they
Yes.
have had any amount of, like, let's say they had one.
Let Tyler answer that question. He's been on the board and he knows this well.
Yeah, it was an exclusion, any prior HPV vaccination. I think I put it in the chat.
But even
Yes.
just one vaccine?
Yes, any prior HPV vaccination. I don't know. They did relax some of the criteria over time. So that might have been one thing that got relaxed.
So people
Uh-huh.
have to go to clinic, and let me wrap up saying that the anchor study is a tantamount effort that proves the importance. Please be proactively vaccinated on those who can benefit. And I hope that once we get the validation and the official release from the journal and the copyright, that we can distribute with whoever wants to use the nomogram as a practical tool rather than to impose, to engage in a shared decision-making with your patients. Thank you for your attention.
Thanks so much, Lalo. Thank you, everyone. Have a good weekend.